honor and privilege and pleasure to introduce a very close colleague of mine. Dr. Nav Persaud is a family physician at St. Michael's Hospital, Unity Health Toronto. He's the Canada Research Chair in Health Justice and an Associate Professor in the Department of Family and Community Medicine at the University of Toronto. He's a member of the Canadian Task Force on Preventative Healthcare and an Associate Editor of the Canadian Medical Association Journal. Nav's interests are very broad and include health equity, medicine selection, and health promotion during early childhood. Nav's talk today is access to essential medicines is more than just a human right. So we're actually spot on the time, and we'll turn it over to you, Nav. I think the plan for today is that there will be questions at the end, and Nav will also be pausing at various points in his talk potentially to take some questions and have some discussion in between sections as well. So we have until 10:30 altogether, so we've got lots of time and really looking forward to a stimulating, interesting, and a talk that I'm sure will challenge us and challenge our assumptions and help us to think differently about one of the major issues of the day. I will I should declare a small conflict in that I have been a participant as a co-investigator in some of this work. So again, and it has been my tremendous pleasure to do so. So over to you, Nav.
Great. Thank you very much, Rick, for that kind introduction. And thank you to the organizers for the invitation to present the Martin Bass lecture this morning. And thanks to all of you for joining. Hopefully you can all see the slides and hear me all right. I'm sure you'll let me know if that's not the case. And if you don't like what I'm saying, obviously you can turn the volume down. I think a lot of people do that when I'm speaking. So first, just a disclosure slide. There's no industry or for-profit conflicts. I receive funding from the federal government and the government of Ontario. And I'm really pleased to have support from those institutions and from my home institutions and others that have supported the work that I'm going to be presenting this morning on behalf of many others. There are going to be 3 parts to this presentation, and I'd be happy to pause after each part to take your questions and to have some discussion. In my brief experience of online conferences, it tends to be more fun for everyone if there are breaks for discussion. Canada is the only high-income country in the world where medicines are excluded from our publicly funded healthcare system. And that exclusion applies even to insulin, which is a life-saving treatment that converted type 1 diabetes from a condition that was almost uniformly fatal to one where the life expectancy rivals people without type 1 diabetes. It was discovered less than a kilometer from where I'm sitting, and Banting and Best sold the rights to insulin for $1. And yet we have patients today who pay hundreds of dollars each time they go to the pharmacy for insulin, and it remains out of reach for many individuals. I've spoken to colleagues who have vials of insulin in their fridge that they give to patients who have trouble affording medications. And we actually had some similar discussions at the family health team where I work at St. Michael's Hospital about what we should do for patients who cannot afford medications. And we had been distributing pharmaceutical samples, drug company samples to patients who couldn't afford medications. And we decided for a number of reasons to stop doing that. One of the reasons was we didn't have samples for many of the most important medications that we wanted to give patients. And the samples were for brand name products that this or that company was pushing. So at a meeting where we were deciding what to do after getting rid of samples, I was sort of tasked as the researcher to decide which medicines we should have on site. And that's actually part of the genesis for both the clinical trial that I'm going to describe and some of the other more international work on essential medicines list, because it was after that discussion that I first found out about the concept of an essential medicines list. As Rick mentioned, he was one of the co-investigators for the clinical trial, the Clean Meds study that I'm going to be discussing today. There are many others from across the province and across indeed the country, and I'm really pleased to present on behalf of everyone. The study could not have happened without the support of many clinicians and administrators across the family health team where I'm based, the Asignac Family Health Team and Manitoulin Central Family Health Team on Manitoulin Island, and the Huron Shores Family Health Team in Blind River, Ontario. And I've had the pleasure of making the drive on the map a few times with my colleagues. And actually, one of my regrets is that some of the meetings that we had canceled as our trial winds down have been canceled. So if any of you are online now, I'm looking forward to being with you soon. So for our trial, we recruited from these family health teams primary care patients who reported that they did not fill a prescription or take a prescription as instructed due to the cost in the last 12 months. So this is cost-related non-adherence as opposed to non-adherence for the other ordinary reasons that people don't take medications. And there are millions of Canadians. Some of the best estimates would put the number at 2 to 3 million who don't take medications as instructed because of the cost. And that could be people who go to the pharmacy, and when the pharmacist tells them how much it costs, they say, well, I'll come back and pick that up later. But they don't because they can't afford it. Would also include people who fill the prescription, but take the medication less frequently than instructed, like every other day, because they can't afford to take it every day or as instructed. So at primary care visits, people were asked if they had this issue of cost-related non-adherence. And then if they were, 786 people from these 4 family health teams were randomized either to have free access to a carefully selected set of essential medicines, or they were randomized in a 1-to-1 fashion, so 50-50 chance to their usual access to medications, which could have included public health insurance if they were on welfare or disability, could have included private health insurance if their employer provided it. And obviously those people could still have failed to be able to afford medications because of the co-payments and deductibles that private insurance involves, or in some cases upfront payments that are later reimbursed. So people were randomized either to free access or usual access, and everyone continued to have their usual access to primary care and other care. So the care didn't differ between the groups. And then we measured medication use, adherence to medicine, surrogate health outcomes like control of chronic diseases, and healthcare expenses. Some more details about the intervention. These are the medications that we provided. There was a list of, depending on how you count them, around 136 medicines. They included antibiotics, treatments for diabetes like insulin, metformin, treatments for depression, schizophrenia, and participants and the pharmacists for the study were provided with the list, as were the clinicians, and they could access them through this website, cleanmeds.ca, that you could still access today if you want to have a browse of the list in more detail. And if you click on one of those medications, you'll be taken to some more information about them and in some cases why they were added to the list and when. Throughout the study, clinicians were and patients were allowed to suggest additions to the list. And I'm happy to talk more about how we were able to create that list during the discussion, if you like. So both the clinicians and the patients had access to this list of medicines on the On the left there, the patient is the one with the heart. And then all of the family health teams use the same electronic health record, Practice Solutions or PSS, and they communicated usually via messages with the single pharmacist for our study. His name is Norm Umali, who, for those of you who have been involved in the study, he was really the face of it, both for clinicians and patients. So prescriptions would be sent, usually using the electronic health record, to Norm, who would then get in contact with the patients, usually by phone, and confirm the prescription and then mail it out to patients, either at their home or another address of their choosing. For individuals without stable housing, that could have been a shelter, some other friendly place, or to their clinic. In addition, if a patient needed to be started on a medication right away, like in the case of antibiotics, or in some cases proton pump inhibitors, those medications were stored on site, and clinicians, prescribers could dispense them themselves on the day that patients were seen. And these were the main results. There was an absolute increase of 11.6% in adherence. And this was, the way we defined adherence was that people took at least 80% of the doses of the medications they were supposed to take, and that they did that for every medication they were prescribed. So there was an 11.6 absolute increase in the percentage of people taking their medications as instructed. And the 80% is a standard definition that's used throughout the literature and in clinical trials of medications when they're being tested for their efficacy. We also found an improvement in hemoglobin A1C after 1 year, improvements in the systolic blood pressure. There was no change in the diastolic blood pressure, and there wasn't really a change in the LDL. This study was co-designed with a group of community members who provided input at various stages, including into how the intervention should be organized. And they also suggested a number of patient-oriented outcomes, and all of this work was supported by the Ontario Support Unit, and we're really grateful for that support. One of the outcomes suggested by the Community Guidance Panel was the ability to make ends meet. We thought that potentially providing people with access to medications that in some cases would only be decreasing their monthly costs by $50 or $100 would likely not ultimately make a big difference in terms of whether or not they could make ends meet. But in the control group, the ability to make ends meet was around 20 to 25%, and it was above 80% in those who were provided with free access to medicine. So make ends meet indicates that people can buy food, pay their rent without incurring debt. So it seems that a lot of people are sort of on the cusp of either being able to make ends meet or not, and relatively small changes in their monthly expenses could make a difference. We also heard about other effects of the intervention, including an increase in the ability to work. So as I mentioned earlier, we recruited people both from rural and urban sites, and one of the individuals who was in the intervention group indicated that due to his asthma and COPD, it was difficult for him to work on his farm when he couldn't afford his puffers, and it was easier for him to do the work that he needed to do as part of this study. And people also talked about some of the shame and disappointment in having to make difficult decisions about what you're going to buy for your family, or having to borrow money from family members to afford medications. And also a lot of people reported that they were surprised when they found out that there was this gap in the healthcare system where outpatient medications are not included, and they talked about what it meant to them to have medications included. If you're interested to hear more of their stories, it's obviously better for you to do that, to hear them in their own voices, and you can go to the website cleanmeds.ca to do that. We've additionally completed some qualitative work and quantitative work of the acceptability of the list. So first of all, although it was just around 136 medicines that were on our list compared with, let's say 2,000 that are on most public formularies for people on welfare or disability, we were able, with equivalence, to cover 89% of all of the prescriptions among intervention group participants. And so that was in some cases substituting, ramipril for other ACE inhibitors, or substituting atorvastatin for other statins. But after doing that, we covered 89%. We specifically targeted in our qualitative study individuals who had medications, who were taking medications that were not covered by the list, to get an idea of how acceptable it would be to them to have just a short list publicly funded. And I think it was fairly clear through those interviews that that having access to some medications made a big difference, even if others weren't covered. And the prescribers, who were in most situations family physicians and several nurse practitioners, felt strongly that an essential medicines list could be a big improvement to public policy if they were publicly funded. The two medication classes where people wanted more medications were antidepressants. So we had, I mentioned that there was an opportunity for people to suggest changes to the list throughout the study. We had a number of suggestions for additional antidepressants to be added. And several times we reviewed the evidence and presented the evidence to the three clinician scientists who voted to decide whether or not a change would be made. And multiple times they decided that based on the evidence, there wasn't really a clear reason to include different antibiotics from the ones that we had included, because multiple studies and systematic reviews have indicated that there aren't important differences between them. But I think one of the practical issues for if this were to be incorporated in a public policy going forward would be to make the list more acceptable. Likewise, as the study was going on, there was evolving evidence for some of the newer diabetes treatment. And the panel of clinician scientists came close a few times to adding some of the newer agents. And, I think it might be the case that if it were to be looked at again today, that some of the newer diabetes treatment would be added to the list of essential medicines. We also, through qualitative work, evaluated this pharmacy model where the pharmacist had access to the electronic health record. And interestingly before we were even allowed to do that, the Research Ethics Board asked us to speak to patients and see what they would think if a pharmacist were allowed access to the electronic health record. And multiple times we got the exact same question, which was, you mean my pharmacist does not have access to my electronic health record right now? Why doesn't my pharmacist have access to my electronic health record right now? Our qualitative study indicated that this was an expectation of patients, that the pharmacist would have access to their record, and it was definitely acceptable. Likewise, there were a number of individuals in the study who, in addition to having cost barriers to accessing medications, had physical barriers. There was an elderly patient who had trouble opening the door to the building that housed her pharmacy, and so would try to limit trips to the pharmacy. There were individuals at our rural sites who lived quite far away from a pharmacy and who really appreciated having the medicines mailed to their door, as is common in some other jurisdictions. There were, though, incidents in terms of the delivery. In fact, the very first medication delivery of this trial was disrupted when the Canada Post vehicle was in a motor vehicle collision, and we were tracking this package because we were very nervous about how this was all going to go. There were also some issues in delivering insulin to from Toronto, from the pharmacy in Toronto to the rural sites. Insulin has to be refrigerated, and there are multiple courier companies who, when you ask them for a quote, they'll say, oh yeah, we can get it there in 24 hours. But when it comes to actually delivering them, you find out that, there's actually only a small number of individuals who are doing deliveries in some of these communities, and there are some practical difficulties in getting medications there quickly. But even with those delays in these direct deliveries, that they're probably not worse than the alternative. A lot of people are also interested in the cost, and it's not a mystery why. Drug spending in Canada is around 30 billion per year, and it's one of the large drivers of health spending, both at the federal level and in every province and territory. So we've done estimates of what would be the cost implications of publicly funding a short list of essential medicines, and because we are overpaying per pill right now, the estimate is that overall we would be saving $3 billion per year, and that would involve an increase in public expenditure where we're moving expenses from out of people's pockets and from private plans over to the public purse to the tune of $1 billion. But the private spending, including out-of-pocket spending, would be reduced by approximately $4 billion. And it might seem hard to believe that publicly funding something could reduce costs to this extent. But the reason is fairly simple. It's because we are overpaying per pill right now in Canada. Compared with our peers, we are paying in some cases double. And that would include in some cases medications that are produced by Canadian companies, Canadian generic manufacturers that sometimes export medicines to other countries like New Zealand and sell them there at a lower price. And in Canada, there's a perverse incentive to have high drug prices because private insurance companies take a percentage of each claim for most employer-based private insurance plans. So that's why we have high drug prices. And if we had lower drug prices like countries that do this in a better way, we'd be saving around $3 billion per year, excluding any direct savings related to improved health. So I think if you all agree, I could pause there and we could have some discussion. I'd be happy to take some questions before I move on to the second part of the Martin Bass lecture.
Okay, well, thank you so much, Nav. So we'll pause here for questions. I'm not 100% sure that I can see the questions on my app. So if there are questions, I'm not actually seeing any, but Mike, if you are, or Elliot, or someone else, or maybe there are no questions, but as I'm viewing the Q&A on the app, I'm not seeing any. So if anybody does see some, please speak up. Or we can ask those in the audience to unmute and to comment or to ask a question at this point.
I'm not seeing any in the Q&A section either, Rick, so I don't think it's just you.
It's Mike then. Can I ask a question?
Please go ahead, Mike.
So Nav, really great, interesting talk. So you were using a kind of a limited essential medicines list versus kind of a full formulary. What are your thoughts on kind of a path forward? If there's would you be more supportive of trying to get a full public formulary Or do you think that in the Canadian context, even getting an essentials medicine list covered for everybody universally would be enough of a step in the right direction?
Great question. Yeah, the idea of an essential medicines list is to include all of the medicines that are needed. And the main way that it differs from the larger formularies, like the public formularies for social assistance recipients, is that usually only 1 or 2 medicines from each class are included, where there is equivalence within the class. And if there are good reasons for including other agents, then they are included. So that's how you go from from a list of 2,000 to a list of less than 200. There are, I believe, at least 14 ACE inhibitors that are approved by Health Canada. There are multiple statins approved. They don't have different effects. There are multiple systematic reviews looking at the effects of different agents within these classes, and there are not important differences. So in terms of improving health, we could meet, well, even if you just look at the percentage of prescriptions, we could meet around 90% of the current prescriptions. And the other thing to mention about that figure is, it seems like if it was closer to 100%, it would be better. But there are sometimes some questions about whether or not some of those other medications should be prescribed at all. We had a number of suggestions, for example, for Docusate as a treatment for constipation, whether that should be added to the list. It's commonly prescribed. And as we compared what's on our list to what is prescribed, that was always flagged as something commonly prescribed off our list. There are multiple systematic reviews indicating that it doesn't work. It's not an effective treatment for constipation. So I would favor, and I would think it would be a big step forward if a list of essential medicines was publicly funded. As I was talking about, though, with the depression and the diabetes treatments, it's obviously important that that the list be acceptable both to clinicians and patients, and that it be viewed as credible. So there's sometimes a negotiation that needs to happen there. The last point I'll say before turning it over to other questions is, lists only grow over time. They never decrease in size. So we would probably have a unique opportunity if we were to move medications within our publicly funded system now to create an evidence-based list. And then over time, there would be lots of pressure from various quarters to add medications to the list. And I don't think there's any doubt that the list would grow over time.
Thanks very much, Nav. We have a question from Larry Chambers asking if you've presented these data to Eric Hoskins, who's leading Canada's pharmacare planning. And I guess I would also maybe expand that a bit to reflections on what's happening at the federal level, what's been in throne speeches, what you see happening, as opposed to what would be, in your opinion, ideal. What are the steps that you see the federal government is making in that direction?
Yes, thank you. So yes, we did provide a detailed presentation to the Advisory Council on the Implementation of National Pharmacare, led by Dr. Eric Hoskins. And they did, the Advisory Council did include a recommendation about creating an essential medicines list. And we've also presented to multiple provincial governments. We've presented to the federal government. And as you might have noted, the throne speech recently indicated, in terms of moving forward on pharmacare, the creation of a national formulary. So we are certainly continuing to liaise with governments both at the federal level and the provincial levels. Yeah, there was a study also by the Parliamentary Budget Office that confirmed the cost savings that I mentioned on the previous slide. So, I mean, I guess people have said this before, but it does seem like there is an opportunity now to advance this area in terms of changing public policy. So, when this study started, some of those who were involved said to me, Nav, are you sure that you want to work in an area where there's never going to be any policy change and governments are not going to be listening at all? Then as the trial went on, people said, well, when are the results coming out? Like, we might get pharmacare before you even publish the results. So it's difficult to know exactly where we are, and I guess sometimes change happens very slowly and then very quickly. So we're trying to make sure that our research is ready for when governments are actually moving forward. And there's obviously a lot to gain from talking about pharmacare, and then we have yet to see it happen.
Thanks, Nav. There's a question about the cost of medications. I can't see the actual wording of the question, so I don't know if you can, or Mike, if you wanted to read the question out. It doesn't seem to.
Sure, yeah, I can read the question. I can't tell who it's from on the app, but it says, thanks for a great talk. Could you expand on why medication cost is high in Canada and who is currently benefiting from this?
Sure. Primarily, private insurance companies are benefiting. Obviously, pharmaceutical companies benefit too from high prices. But the reason they're high is because there are multiple payers for medications. In other countries, like in New Zealand, where there's a central negotiating for medication prices, the costs are much lower for exactly the same medications. And here there are perverse incentives to have high prices. Insurance companies take a percentage of each claim. And so they're willing, first of all, to cover basically any medication, including medications that don't work or that are dangerous. And they are additionally very happy to pay high prices. And there are a lot of shenanigans that happened where insurance companies and even public funders agree to a public price that is way higher than they are actually paying. And then they negotiate a lower price. And so then in those cases, the only chump paying that high list price is the individual who doesn't have insurance, either public or private, and is going into the pharmacy and taking money out of their own pocket. So it's a really terrible system. And if there's guidance from the World Health Organization, there are examples from other countries that are doing this better. I think, I would just compare, there's, like researchers like the co-investigators I mentioned on an earlier slide, and who send the government research studies that are pages long and have appendices. And then, there are others who know of better ways to reach the government. And right now we have a system that's not working very well. And there's a clear solution that's been articulated in multiple government reports, and hopefully there will be change.
Thanks very much, Nav. We have a question from Moira Stewart that says, great study. Please tell us more about what the patients said and how patients contributed to this study. I know, Nav, you've been a leader in the field of patient engagement, and I know that patients were absolutely involved in the study. So this is a terrific question.
Great, thank you, Moira. Yes, so from the very beginning, before we even started the trial, we canvassed the area around St. Michael's Hospital wearing t-shirts that said "Free Medicines?" ? And we handed out pamphlets telling people that we were planning to do a study addressing this problem, and that we wanted input from the community. And we were able to recruit, mostly through that method. We did random digit dialing also, and also engage people through existing community groups. We were able to establish a community guidance panel that started out with 12 community members who reflected the diversity of the city and of Canada. And they provided input on how the intervention should work, what should be the study outcomes, including the make ends meet outcome. And also, several of them were on hiring committees when we were hiring research staff for the study. I think it's fair to say that if we didn't have this community guidance panel, we would not have included that outcome around the make ends meet, which could arguably be the most important outcome, and that, for my part, has informed some of the follow-up studies that I would like to do. So the involvement of community members has been really crucial. And so we're really grateful. Initially, actually, it was the Toronto Central Local Health Integration Network that provided some funding to help us establish this panel. And then later, lots of support from the Ontario Spore Support Unit. And I'd be happy, we have some documents, like we have a terms of reference for the community guidance panel. We have minutes from each meeting. So if others are thinking about doing something similar for a trial or a program of research, obviously I'd be happy to talk and happy to share the materials.
Thanks, Nav. We have a couple more questions, but I don't know if you want to go on to some other parts of your talk and then we'll pause again. What do you think is best? We've still got lots of time, but just over to you for how you'd like the flow to go.
Sure. I mean, I could continue, and then maybe you could just make a note of your questions if they're not submitted electronically, and then I'm definitely going to leave time at the end for questions.
Yeah, I am able to see them now in the app, so I'll just give you a heads up. We're seeing a question about generic versus brand name and barriers for governments implementing pharmacare. So if you'd prefer to address those now, or if they fit better later in the talk,
yes.
That's either way is good.
Great. I think both of those fit well at the end, and so let's make sure that we don't forget them at the end.
Yeah, and now there's one other question in the other Q&A. Some people are still in the opening session, so there's two parallel Q&As going, and it's about drug interactions and having more than one medication in certain groups when that's an issue. Sure.
Okay, so maybe I'll take all of those at the end. So I just made a little mental note here. So the next two parts are shorter, and I'll pause after the second one. So when we were engaging with the Advisory Council on the implementation of national pharmacare and the other provincial and federal decision makers who were mentioned during the question period, one of the common questions that came back to us is, what do you mean by essential medicines? What are essential medicines? What medicines are considered essential in other countries? What are publicly funded in other countries? And how can that inform what we do here? So the World Health Organization created a model list of essential medicines in 1977. And the idea of the model list was that each country should then adapt the list to their own circumstances, prevalence of diseases, size of the economy, et cetera, and then ensure access to those medicines. So ensure that those medicines are stocked in pharmacies and hospitals across the country, and ensure that they are actually accessible to patients, like patients can afford them. And since then, 137 countries have created national essential medicines lists, and in some cases subnational lists, like for states or provinces within a country. And so we asked the World Health Organization, what are the commonly listed medicines, and how do they compare with the model list? And the WHO said, great question. We don't know. And over time, you've heard some discussions recently, I think, about the limited support for the World Health Organization. And, is currently, I can tell you, like a single office with 2 people in it, the Essential Medicines Program at the World Health Organization. So they said, we don't know which medicines are listed by other countries, and we would like to know. So we, over several years, found the essential medicines list documents for 137 countries that in total listed around 2,000 unique medicines. And there were a lot of people involved in this work. And I think if we had known how much work it was, we probably would not have done it. But we eventually were able to create a database of all of these essential medicines lists. And there's a lot of good news, I think. So, there are some effective medications like antibiotics, metformin as a treatment for diabetes, that are listed by virtually every country. And then, another example of good news would be cardiovascular treatments, like treatments for high blood pressure, And statins are listed by almost every country. There are several international standards for which medications are the priority ones for cardiovascular disease, and we've used 3 different definitions in one of the published papers, and found that around 90% of the countries are listing all or almost all of the priority cardiovascular treatments. There are some surprises though, like treatments for tobacco dependence, like nicotine replacement therapy, bupropion, varenicline are not listed by most countries. Actually, the vast majority of countries list none of those treatments, despite the global burden of tobacco-related harms. So those are some of the comparisons that we can do just looking at the list. We can also try and understand some of the differences between individual countries' national lists and the WHO's model list. And we found massive differences between some countries' lists and the WHO's. And you might say, well, that is the point, like countries are supposed to adapt their list, but some of these countries, they would have added, in some cases, like 600 lists on top of the several hundred that are listed by the WHO. And there are big differences between countries in how much their list differs from the WHO's. And it is, I think, hard to imagine why, based on disease prevalence, there would be these big differences, because it's actually, if you get down to it, hard to name conditions that only exist in some countries or regions in the world that have a treatment that's unique. There's actually a fairly small number of those conditions. We've also more recently then done deeper dives in particular areas. So one example is avoiding antimicrobial resistance through smart selection of antibiotics. And the WHO has elaborated some guidance on which medicines, which antibiotics should be prioritized, and which should be held in reserve in order to avoid antimicrobial resistance. And so we've looked at the actual listing of antibiotics, and the map in the top left just shows the extent to which, darker being like more coverage of the priority treatments that should be available. So you can see there's some differences there. The bottom left graph shows, so the dark bar is those medicines that should be widely available, commonly used antibiotics like amoxicillin. And then the lighter bar shows those that should be held in reserve. So you can see that there's some discrepancies where some countries are actually preferentially listing these medicines that should be held in reserve. And some of these countries do not list the priority treatments that should be widely available. On the right, we've also looked at it by condition, and darker means better coverage. And so, there's certain conditions like meningitis in neonates where there's not very good coverage across countries, and even in the WHO list. And so we've identified through these comparisons some potential changes to the WHO's model list, and also some changes that countries should make to their national list. Those changes that countries should make to their national lists, so we've been working with countries and providing advice, and what we have found through that work is that they do not necessarily respond well to having their list compared with the WHO's list. In some cases, they think the WHO's list is, out of date, even though it's updated every 2 years, or not relevant to their circumstances. So what we've also been doing is comparing lists between countries, irrespective of the WHO model list. And I think one of the most striking things that we found is that most of those 2,000 medicines that are listed by at least one country are listed by only a handful of countries. And And it is actually hard to explain why there would be a good reason for that. Again, there just aren't that many conditions that would be unique to just a handful of countries. And when we look more carefully at some of those lists, especially some of the long national lists by countries who may not have the strongest healthcare system, we find some concerning medications are actually prioritized for access. And some are listed here. I'll just go through maybe two examples. Cisapride is an example of a medication that was removed from the market in Canada, and eventually other countries also struck it or banned it because it was associated with sudden death due to arrhythmias, and an MP, Terence Young, has written about the death of his daughter, and has really played a leading role in more transparency around reporting of adverse events. And all of this happened decades ago in Canada, and yet 9 countries prioritize cisapride for access today. Phenobarbital is it's a treatment for asthma that works similarly to salbutamol, and is as effective as salbutamol, in fact, but it also causes sudden death, and that is and the risk is not comparable to other agents in the class like salbutamol. Phenobarbital is also more expensive than salbutamol, partly because it's been banned in multiple countries and it can only be sold in certain places. Yet 31 countries listed in their national essential medicines list, and some of those countries do not list salbutamol. And so we've moved from, in addition, comparing with the WHO standard to comparing between countries, and we've looked within regions here, controlling for the size of economies, which is, reflected in the size of the bubbles here, looking at how the lists differ in which medications are added and which medications on the WHO list are not there. And we have found through our work that this is potentially a more productive way to engage with countries around changes to their list. And we have created a template for generating customized reports for each country, where we tell them which medicines they're listing that their peer countries in the same region, the same similar GDP, do not list, or the converse. So medicines listed by others, not by the individual country. And we also provide a brief summary of the evidence around these medicines, and then ask these countries to consider changes. If you're interested, you could do the same thing, actually, because the database is available at our website, essentialmeds.org, which is now co-hosted with the World Health Organization, and has some other information from the World Health Organization about essential medicines lists. So if there's a specific country or part of the world you're interested in, you can navigate the website that way. You can also look at it by medication. And I think that brings me to the end of the second part. So I'm happy to pause here for some questions. The last part is going to be shorter, so we have some time for discussion now.
Okay, well, thanks very much, Nav. Reflection that I'll make is we talk about evidence-based medicine, or these days evidence-informed healthcare, and it sounds like your work has really identified factors other than evidence that are driving really important decisions about coverage and prescribing of essential medicines around the world. So I'll just kick off some of the questions related to this last section by asking you why you think this is happening. Is it pressures from pharmaceutical companies or from insurers? Is it you've said there are local factors, and in some cases, of course, those local factors could include need, but could also include political pressure, I suppose. Some may be inertia with drug lists that are just not up, they're still listed, but have not been updated. So just interested in your reflection on the lack of what we would say evidence information is in one of the most costly and rapidly growing costs in all of healthcare all around the world, which is pharmaceuticals. So you're certainly addressing a critical topic to the sustainability of healthcare systems around the world and identifying a situation that could be considered pretty chaotic and not informed by evidence. So just your general reflections on that, and then we'll go to some of the specific questions.
Thank you. Yeah, so I think there are pressures from drug manufacturers, sometimes from patient groups, to list medicines that might not be effective or in some cases would be dangerous or lethal. And it can be a resource intensive process, reviewing all of the evidence for all of the medications that might come before a committee. And I think the reality is that some countries don't have the resources to do a detailed review of each suggested addition to their list. And as you mentioned, they may also not have resources to update their list and remove medications once they're added. So I think that's one of the primary gaps. And I also think that it's one of the areas where Canada could play a leadership role. The drug assessments in general, most parts of the drug assessment will not differ between countries, right? The primary part is looking at the effects of the medicine based on clinical trials and observational studies. So that could be done once by one country or by one institution. And we don't have to have every low or middle income country waste resources reviewing every single medicine. So, if we had an essential medicines list in Canada and we were transparent about how decisions were made and we publicly posted knowledge syntheses and summaries of effects, other countries could then do, a relatively small amount of work in just thinking about whether or not they even need that medicine, whether the condition is prevalent there or not, and whether or not they have the other elements in their healthcare system to use the medicine, like the testing that might be needed for monitoring, whether or not clinicians could prescribe it. So we could play a leadership role there. The WHO could also do that. And I think the reality is the WHO also has limited resources.
Okay, thanks very much. We have a question, and we're seeing questions in the general chat and in the Q&A, and both of those are fine. And if anyone would like to unmute to ask a question, that is also fine. So question was asked about, can you talk about perverse incentives? A bit about how generic versus brand name meds or pharma companies impact this. So you haven't kind of mentioned pharmaceutical company, trade name companies versus generic, and how those kinds of issues factor in either to the drug lists or how they're used or what coverage decisions are made or how coverage decisions are made.
Great, thank you. So yeah, first of all, we always use the medicine name, not the product name. So the medicine name would be the same whether we're talking about a generic product or a brand name product, which in many cases would be a patented product. Most of the medicines on the essential medicines list that we used in the trial and that are included in the WHO's model list are not protected by patents. It's a bit more difficult to talk about patents internationally, right? Because patents are usually enforced at the national level. So there can sometimes be some uneven patent protection. But by and large, we're talking about medicines that are not patented. I think, there are examples of patented medicines that could be highly effective. Some of the treatments for hepatitis C, for example, would be very expensive patented medicines, some cancer treatments. Although I think there are more questions about the effectiveness of the newer oncology treatments. And I think sometimes there are some really striking examples where low-income countries don't list some very inexpensive antibiotics or salbutamol, but then they do list expensive products that sometimes are protected by a patent, and you wonder what's going on there. If you look at those same countries and ask questions about what's the process, like who's on the committee, and and what evidence is reviewed, sometimes the answer is a little bit vague. So you do wonder. And sometimes manufacturers would hold some sway in countries where they are based, or where they would argue that they support the local economy. So yeah, there can be an effect of the brand name manufacturers, but by and large, most essential medicines used would be generic.
Thanks very much, Nav. Maybe one more question before we move to the next section. And there are some more questions coming up for the end, but just wanted to ask, what are your thoughts on having traditional medicine covered for Indigenous patients, knowing that the practice cannot be separated from the medicine, as is the way in Western practice? And I guess this is a question maybe about the Canadian context, but maybe this comes up in international contexts as well. So just be interested in what you've encountered and any ideas or suggestions in that realm.
Sure, great question. All medicines that are needed should be on an essential medicines list. And certainly each country should decide what criteria they're going to use and how they're going to be evaluated. Just to give a very different example, it's clear that treatments for so-called rare diseases or infrequently encountered conditions should be included in essential medicines list because they're needed. In some cases, the difference between life and death for individuals with these relatively rare conditions. But the standards for adding them to the list need to be different because there are not going to be large trials for these medicines. And there are different standards. So I would totally agree that for different categories of medicines, we should have different approaches. And I'll just say, for example, some national essential medicines lists do include traditional Chinese medicines, for example. And in some cases, they're included in the list proper, and they're treated exactly the same way as other medicines. In other lists, they are listed separately and have a slightly different status. So I think, and if there are others out there who are interested in thinking about how this should play out in Canada, I think one, I would be really grateful to be involved in those conversations, and I'd be happy to help in any way. And two, what I could say for sure is that there would be international interest in that type of work because it would absolutely apply in other countries.
Thanks, Nav. Just one last question before the last section. So this came in through the chat, is in the context of essential drug lists, medication lists in Canada and around the world, what is the relationship, if any, between those lists and the issue of drug shortages? So we've seen during the COVID pandemic, the issue of shortages, but long before that as well, we saw outages and shortages of a number of medications, and there could be, currently we have a disruption due to a global pandemic, but there could be many other reasons why there are disruptions to medications, to medication supply. And we've also seen certain manufacturing defects that have meant that certain medications have been withdrawn from the market, and we've had to rely on a different proton pump inhibitor or a different, anti-diabetes medication because a particular formulation had a problem. So I wonder if you could, this came in from the chat about kind of the relationship between essential drug lists and maybe narrowing, the number of medications and the relationship there with both Canadian and international supply and shortages.
Great question. Yeah, I mean, essential medicines, this concept developed in the 1970s, was supposed to address this issue of drug shortages and also, address the issue of fake medicines and low quality medicines. And, I think the fact that we don't have an essential medicines list in Canada, it helps to illustrate why the problems that we're having because we don't have one helps to illustrate some of the potential benefits of an essential medicines list. If we had an essential medicines list, then it would actually be possible to try and ensure in an organized fashion, like involving the government, that there always was an adequate supply. So because these products are, as I was saying, virtually never patented, there should be multiple suppliers. And if there was an agent that only had one supplier, that would be something that could be addressed. Likewise, it would be easier, not easy, but easier to inspect these facilities to ensure the quality. So we wouldn't run into these problems where we scramble, where there's a medication that's of a poor standard, and then we have to switch medicine. So it wouldn't guarantee that we would never have a shortage again, because there are other reasons for shortages, but it would likely reduce the likelihood. And actually we have some ongoing studies now looking at shortages and listing in essential medicines list. And yeah, I mean, I think the original plan to avoid shortages through essential medicines list has worked.
Thanks very much, Nav. I'll invite you to carry on with the third part of the talk. We have about 15 minutes left, and we do have a few questions for the end as well.
Great. Okay, I'll go through the last part relatively quickly, because I think it's very straightforward. I mean, the fact is, there are human rights that exist across this planet, and there's a good reason for human rights. In part, it's to protect people from powerful forces, including from governments that may, at times, act in ways that are harmful to people. And that could be through violence. It could also be through deprivation. So we all agree, obviously, Canada is a signatory to all of these international covenants about rights that everyone in the world should be ensured. Those rights include the right to health, and essential medicine provision is definitely a core obligation. There's really no question about that in international law. And there are multiple documents, multiple court cases in other countries looking at this. And one of the reasons for bringing it up here is, when we're talking about rights, we're talking about something that governments have a duty to do, not something that they might like to do if they're reelected, or something that we should give the Prime Minister an award for if they did. It's something that they have a duty to do. And in the case of essential medicines, people die without them. And there are examples in Canada that we could discuss in the discussion section about where a focus on human rights has helped to advance public policy in Canada. I think there are some advances in housing now at the national level. And if you read government documents, they rely heavily on international covenants. And similarly, in reproductive rights, actually internationally, Canada promotes reproductive rights and supports both public and non-governmental efforts to ensure the protection of reproductive rights in other countries where governments sometimes are not fulfilling their duty to protect reproductive rights. And so, my suggestion is that, we should apply some of the same thinking that we're currently applying to COVID to all essential medicines. It's clear that if and when there's an effective vaccine for COVID, it's going to be publicly funded. Access to it won't, in Canada, depend on your ability to pay, similar to other vaccines for infectious conditions. But this year, chronic diseases like diabetes, high blood pressure are estimated to kill around 24,000 people in Canada. And we know that the burden is going to fall disproportionately on people who have a low income, including racialized people, including people facing discrimination for other reasons. And we all agree that everyone should have access to the COVID vaccine. But so why not insulin? Why not Ramipril? Why not treatments for schizophrenia? Maybe I will. I'll wrap up here by saying we know, based on the clinical trial that we have done, that providing people with free access to medicines can improve health. We also know that Canada could play a leading role in improving essential medicines lists around the world. We have the resources to do it. And in fact, when I give presentations at the WHO to other countries, people are quite happy to hear from a Canadian talking about medication selection, because CADIT and others who do knowledge synthesis in Canada have an excellent reputation that I ride on the coattails of. So I think we would be well placed to improve health internationally, but all of that should not distract us from the fact that human rights apply even to people in Canada, to people in Ontario. And so one of the first things that we should do is ensure that people have access right here to essential medicines.
Well, thank you so much, Nav. Absolutely terrific and thought-provoking talk. We do have about 10 minutes left for questions, and I really appreciate the pausing during the presentation and having a much more interactive kind of format, which was your suggestion, Nav, rather than saving all the questions to the end. So I think that's worked extremely well. We do have more questions, and I'll invite others to put it either in the chat for the section or for this session or in the overall chat. So we had a question earlier about, do you have insights on the impact of OHIP Plus on health outcomes or access since its implementation? Is there any research being done on this?
We had a proposal to do some research. I think, given all of the changes that happened with OHIP Plus and its eventual virtual cancellation, I think none of the plans for evaluation that I was involved in went forward. I think it showed that this piecemeal approach, we already have this patchwork approach to medication coverage. There are private plans, there are various public plans. I don't think anyone ever thought that the solution was to add an additional plan for individuals younger than 25. What I can say is it did not have some of the expected economic benefits, like insurance premiums did not change at all, even though expenses for insurance companies moved over to the public books. It's currently created this situation where you have to demonstrate that you don't have private insurance before you can be enrolled. So I think my assessment, is that it has not been a success.
Thanks, Nav. A question came in saying, "This is thanks for an excellent talk and this work. In ways, so the question, I guess, is there an equity audit happening on the essential medicine list for the Ontario trial?" So I guess the question speaks to the equity considerations, I think, beyond supplying medications to people who have difficulty affording them, which of course is a pro-equity move in and of itself. If you've had a chance, or colleagues or others, to look into the other equity dimensions of the trial.
Well, we looked at other effects, like on the ability to make ends meet. Maybe here I'll just mention one of the most important limitations of the trial, which I think is relevant to the question, which is that we recruited from primary care sites. Now, what if you had high blood pressure and you continuously went to your family doctor and they said, here's this medication, and you couldn't afford to get it? And then you went back and your doctor said, yeah, your blood pressure is still high. Why would you continue going back? Obviously we're also into other issues around who can access primary care. Like if you work in a factory or you're a taxi driver and you have to work all day during the day, what's the likelihood that you even get diagnosed with high blood pressure? So what I think would be best, and we did this trial in primary care for reasons that you can imagine, like we needed people who were being prescribed medicines in order to measure the effect of free access. But I think, if you're primarily interested in equity, this is not the ideal population. And I think we probably excluded some of those who are hurt the most by systemic inequities.
Thanks very much, Nav. I guess we have that problem when we measure access to primary care by talking to people in the waiting room or after their appointments, because those are the ones who have achieved access. We have a really interesting question from Maggie McNeil. Was there any indication that your study participants were hindered by a lack of access to assistive technologies such as glasses, walkers, chairs, etc., wheelchairs, as well as medicines? I've seen some work suggesting the need for essential assistive devices as a sibling to the list of essential medicines, or assistive technologies, I guess I would say more broadly.
Thank you. I love that thinking. I mean, that's sort of where I'm thinking now. You know, medicines apply to a relatively small fraction of the population, if you think about it. And, you know, so some of the follow-on work from this is thinking about what else is essential. And so we've done a systematic review of how can you improve health by providing people with free goods. And so, you know, people have looked at things like food, hip protectors for protecting, for reducing the risk of hip fractures, access to transportation. And I think assistive devices, there was actually one trial of that had a small benefit. So yeah, I think we should move beyond thinking about medicines and like going back to the previous point, I think for a lot of people, medicines were not the most important thing that they lacked. Now, obviously, providing people with free access to medicines could free up some funds so that they could buy other things. But still, I don't think, and we got that feedback actually from people through the qualitative research. People said, yeah, it's nice that I can afford my diabetes treatments because I wasn't taking them anymore. I wasn't taking them before, but I still can't afford to eat the healthy foods that, you know, the dietitian and my doctor are recommending for me. So I'm eating like canned pasta. So it doesn't really make sense to provide someone with access to expensive treatments when they cannot afford healthy foods.
Thanks, Nav. There's time for one or two more questions. So one that came in earlier is that in some countries, patients can buy antibiotics over the counter without a script. So it raises a question about, you know, in addition, is needing to see a physician or a nurse practitioner a barrier to accessing medications? So there's the issue of pharmacist prescribing that is present in several provinces in Canada, and also taking medications, you know, off the list of things that need to be prescribed by a health professional. I don't know if in your you know, research and examination of international practices, if you have recommendations where things maybe don't need to be limited by a healthcare worker prescription.
Yes, it's a great point. First of all, I didn't present it, but we also looked at the appropriateness of prescriptions written, and that was part of our outcome, whether or not these prescriptions were appropriate. And using this short list of medicines does increase the likelihood that prescriptions are written appropriately, that there aren't potentially harmful interactions between medicines. And I think that was one of the other questions. In terms of making them available without a prescription, when we think about appropriateness, there are probably some examples where it could potentially increase inappropriate use. Antibiotics would be one example. However, it's not totally clear, and obviously antibiotics are sometimes prescribed inappropriately in situations where the patient probably wouldn't. Like the prescriber just writes a script because they think that's what the patient wants and that will get them out of the office. But in fact, that's not what the patient wanted. So it could reduce inappropriate use. You know, and I've seen some proposals, actually. One of the more interesting ones was for antidepressants. The idea being that similarly, clinicians sometimes just prescribe an antidepressant because they think that's an easy way to end the encounter. But, you know, there's some thinking, I think Dr. David Healy has suggested that potentially if they were available over the counter or maybe behind the counter, that there would be less inappropriate use of those medicines. And, you know, there are additionally some studies looking at wide availability of polypills that would include statins, that in some populations at a high risk for cardiovascular disease, if you circumvent the need for a prescription, you can get the medication into people who need it with limited negative consequences.
Thanks very much, Nav. We're at 10:28. At this point in the proceedings, we would all be clapping, if not getting on our feet. to clap. I think this has been a tour de force, an amazing overview of an area that anybody who'd like to unmute and clap, now is a really good time to do that. So we can try a virtual ovation. Some things that don't translate quite as well virtually, and that might be one of them. But anyway, Nav, an absolutely fantastic talk, thought-provoking, as always. This is the result of deep and persistent inquiry that you've had, starting with curiosity and a marvelous question, and leading really to pushing health policy in Canada and internationally. So I want to thank you very much. You've been an extremely appropriate Martin Bass lecturer, and I think we all enormously appreciate the contributions that you are making to health and healthcare in Canada and around the world.